Hi, everyone. Good evening. Good evening to those who are joining from home and who are not at Vision Expo West. If you're at Vision Expo West and you're joining, you get the gold star for double work today. I am excited to welcome you to tonight's webinar, tonight's WU University webinar with WU favorite Dr. Tracy Offerdahl. Tonight's topic is Metabolic Disease Update, Exciting Drug Options for Diabetes and Weight Loss. Let's see. Dr. Offerdahl is having a little bit of tech trouble tonight, so we're working through it. Welcome to the real world. I'm your host, Dr. Jennifer Stewart. And just some reminders, some housekeeping reminders. For every hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. Also, the survey link will appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with your OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and please feel free to ask questions throughout the presentation using chat or Q&A. If you're on a mobile device, you can find Q&A at the top and chat behind those 3 dots. It's my once again and again and again pleasure to welcome Dr. Tracy Offerdahl. I think this is our 5th, 10th, I don't know how many times we've paired. Even in the last couple of weeks, we've paired together. So it's my great pleasure to introduce once again Dr. Offerdahl. She attended Temple University School of Pharmacy in Philadelphia for both her undergraduate and graduate degrees. Upon completion of her Doctor of Pharmacy degree, she completed a residency at Temple University Hospital. She's currently on faculty at the Pennsylvania College of Optometry at Salus Drexel University in the Department of Optometry, where she is the course director and instructor for all systemic pharmacology courses for students in the optometry, audiology, and physician assistant programs. Additionally, she's a practicing clinical pharmacist, and she's a fellow in the American Academy of Optometry. Welcome again to WU, Dr. Offerdahl. I'm going to turn it over to you.
Thank you so much. So financial disclosures, the only thing I really have is a non-salaried affiliation agreement with Pharmanex. I'm a biophotonic scanner operator, and the most important thing, all financial relationships have been mitigated, certainly for the purposes of this discussion. So that's what we have here tonight. Metabolic disease update, exciting drug options for diabetes and weight loss. And I know probably all of you that are joining us here tonight have heard of the new peptides that are out, or relatively new, for weight loss and type 2 diabetes for sure. And it's important to understand the significance of peptides in general. I was listening to a podcast or reading something about peptides in the last few months because I'm just completely fascinated by them from a biochemical perspective. But it said, you know, in nature, there are trillions. There are trillions of peptides. Peptides are just structures that are made up of amino acids. And the remarkable thing about this discussion tonight is that now we actually have peptides in terms of our glucagon-like peptide 1 receptor agonists, right? Or semaglutide or tirzepatide, and our glucose insulinotropic peptides as well, which is the tirzepatide component with the addition of the GIP. And these are life-changing for people who need them. I am not someone who typically would say, I'm really excited about this drug, or these drugs are phenomenal, particularly when they are new chemical substances. You know, I'm always the one that's going to be the crunchy granola gal that's, you know, looking for supplements, or, you know, looking for what I need in food, et cetera. But that doesn't always work for everybody. So some exciting discussion we're going to run through tonight, and hopefully you're going to learn some new things. So why would there be this component kind of talking about like choose your parents wisely, which is sort of tongue in cheek, right? We can't really choose our parents. So if you've heard any of the discussions with me about functional medicine and, you know, different ways to approach patients from an antioxidant perspective, et cetera, on other WU events where I've been the speaker, I've probably shown you this slide or some version of it, some iteration of it. And the important part here is really twofold. It says lifetime health, 8, 9, 10, 11, 12% of what we have going on in our body comes from our parents. And of course, we have no control over that, right? But what you need to understand is that this discussion about metabolic disease and then the addition of these, wonderful newer agents that are being used in our patients, this is a game changer in the sense that we are able to, with appropriate diet, nutrition, and now these biologic agents that are our GLP-1 receptor agonists, et cetera, we are able to actually change genetic expression of certain factors in our bodies. I mean, we've always been able to do it, but it's just now sort of combining really, truly functional, holistic thinking along with Western medicine in patients who have type 2 diabetes and or overweight, very overweight, or extremely overweight. So 92%, 88 to 92% is our epigenetics, and that is influenced by lifestyle choices, our exposures over the course of our lifetime. And this plays a humongous role in metabolic disease. So again, just kind of showing you what you've heard me say many times if you've heard me speak, is we have not only endogenous, but we have exogenous free radical formation. So just as we sit here, maybe you're relaxed, you have a cup of coffee, cup of tea, whatever, and you're breathing in and out, the free radicals are forming. If you stopped by on your way home and had a beer or a drink with one of your friends, oxidative stress, UV light, too much of it, oxidative stress, metabolic issues, smoking, air pollution, ionizing radiation. I mean, the list goes on and on and on and on. The point is, our bodies are constantly fighting against free radical formation, even as a normal function of our endogenous systems. We have to make sure that there is enough antioxidant protection to cover us in terms of the free radicals that are in our bodies. And there are lots of hidden stressors that we don't even realize, are going on and that we're exposed to. So the exposome is the discussion of the measure of all of our exposures over the course of an individual lifetime. So over the course of my lifetime up to almost 55 years old, and how they impact me in terms of my health. We were created to be self-healing organisms. Wherever you think you came from, that's how we were made. And unfortunately, our exposome impacts our ability to really be self-healing. And that's really the wonder of peptides that are available in nature, and then peptides that we use as biologic structures and drugs. So again, to kind of tie all this together and then see where this sits with metabolic disease, because they cannot be separated. This chronic inflammation, and actually I just said to like Chat GPT, I was like, tell me about chronic inflammation and slow burn inflammation. And this is exactly kind of what popped up with that AI component, which I thought was interesting. It's an excellent discussion or a couple sentences here. So chronic inflammation is a long-term state of inflammation that can last from hours to years. It's also known as slow burn inflammation. That's what I usually call it. Or sometimes I call it subterranean inflammation, because it's a silent thing and it can have a significant impact on all of our bodies, not only from the heart to the metabolic system, but in cancers, dementia, other autoimmune diseases, macular inflammation, macular degeneration, glaucoma, geographic atrophy. The list goes on and on. Chronic inflammation is a hallmark of many chronic diseases and is linked to some of the leading causes of death in the US. So some causes of chronic inflammation may include lack of exercise, chronic stress, obesity, poor sleep, use, and an unhealthy gut microbiome. It's some people call it the body on fire, which I loved. It's so true. But we have control over many of these things once we can identify that as a problem. So this metabolic syndrome is a cluster of conditions, and this cluster of conditions becomes, sort of cumulative over time. And that's why when you think of a typical type 2 diabetes patient, or a patient, with type 2 diabetes, I should say rather, it can be 10, 15, 20, 25, 30, 35, 40, 45, 50, 55, 60, 65 years before they really start to have type 2 diabetes. It takes a long time, and it has to do with this slow burn subterranean inflammation that ultimately not only is affecting the patient metabolically, but it's causing, again, like insulin resistance, elevated blood glucose, et cetera. And it's all contributing to this list of issues that we'll look at in more detail. So this is just kind of the little pinpoints for what qualifies as metabolic syndrome. Elevated glucose, specifically looking at insulin resistance. Insulin resistance is key. 100, greater than 100 milligrams per deciliter fasting blood glucose, hemoglobin A1C greater than 6.5. So even as you're approaching 6.5, it's not normal. So, I mean, 5.6, 5.7, that's a normal hemoglobin A1C without metabolic issues and without, insulin resistance. But once you're approaching, 6.0, 6.1, 6.2, that is a metabolic issue that is due to probably insulin resistance and that subterranean inflammation. High blood pressure, specifically looking at the systolic. Being overweight, very overweight, or extremely overweight, BMI greater than 25. Doesn't take very much to have a BMI greater than 25. That's easy to do. Abdominal obesity is always more problematic, looking at the visceral fat, particularly in men, and sort of that estrogenic fat in women. Sometimes you see the pendulum obesity, we call it, in patients, particularly problematic in women. Abnormal cholesterol ratios or dyslipidemia, very specifically looking at, notice the LDL is not here, looking at high triglycerides greater than 150 milligrams per deciliter, and a low HDL, a low good cholesterol, less than 40 milligrams per deciliter. The number one treatment of low good cholesterol, low HDL, exercise. There are really no good drugs out there to treat that problem. And then causes of metabolic syndrome. Again, there are a lot of parameters that kind of fall into that, what can cause it. When you have 3 or 5 of these metabolic syndrome issues over here, we know that your chances of heart disease, stroke, diabetes, dementia, cancer, macular disease, glaucoma, the list just goes on, increases. I liked this graphic. It was just something I found recently. So drugs and environmental toxicants, metabolic syndrome, altered responses and toxicity. So this is just showing you what are the components that make up metabolic syndrome, and what are the issues that can occur from long-standing metabolic syndrome. All of these problems over here are and the end point of, sort of end organ disease in some cases, but all as a factor of this slow burn, body on fire, subterranean chronic inflammation. So we need to be able to, figure out our own equations to see what works. Again, just as a quick reminder, and we're going to jump into the drugs here pretty quickly, but as a reminder, you guys as optometric physicians know better than many other medical disciplines. You already know the importance of good antioxidant protection, right? This is why you use your lutein, your zeaxanthin, sometimes your mesozeaxanthin, and fish oil, and all these other things to, kind of protect the eye if somebody has a family history of macular disease or a patient has an actual history of macular inflammation and disease. You already know the significance of antioxidant protection. Why do we do this? Why do we use it? Well, look over here. This is a healthy atom inside a human cell. So notice there are paired atoms, or paired electrons rather, these little orange dots. These are paired electrons, and this is a healthy atom. You need to have these paired electrons. If you do not, then you'd have a free radical. So this was a healthy paired electron healthy paired electrons, there were 2, where one of them went missing because some body or, some other function in the body, oxidative stress, needed to use that electron to make a healthy atom. The problem is, if we don't have enough antioxidant protection, then we walk around with a lot of free radicals, which are unpaired electrons in an atom. And when our our human cells then need to replicate. They're going to replicate irrespective of what the paired electron situation looks like. So your body is looking for extra electrons all over the place. That's our antioxidant protection to make fewer and fewer free radicals. If there's not enough antioxidant protection to mitigate some of the free radicals that are floating around, then your body is now replicating a damaged human cell with atoms that are free radicals. Your body's going to replicate human cells. It has to, as part of homeostasis and maintenance in the body. If you don't have enough antioxidant protection, it's just going to replicate damaged cells with mitochondrial dysfunction. And over time, this is the slow burn chronic inflammation. And this is also why antioxidant protection is so important. So when this occurs, we sometimes end up with these diseases and conditions, including diabetes. So just as a real quick reminder, because we're going to jump into the drug therapy here, type 1 diabetes, generalization, but generalizations work because there's, a kernel of truth or lots of truth associated with them. Type 1 diabetes generally is full-blown pancreatic dysfunction. The beta cells have been destroyed, and now we need to replace endogenous insulin with exogenous insulin injections, or if somebody has a pump, right? Type 2 diabetes is a little bit different. Type 2 diabetes is really the definition of full-blown metabolic disease, where we have insulin resistance in tissues, where we have way too much insulin being produced, swirling around the bloodstream, because unfortunately the body has sort of forgotten what it needs to do with those insulin, with the insulin, to just lower blood glucose and start using that blood glucose as fuel in peripheral tissues, skeletal muscle. The liver needs it, some in the adipose tissue, et cetera. So we need blood glucose to be used as fuel. Unfortunately, with this insulin resistance, otherwise known as a decrease in insulin sensitivity, what happens over time when you have just chronic high blood glucose because of not balanced eating, not eating protein and fat first, and then starches and carbs last. So if you have chronic high normal blood glucose levels, your body's just, spitting out more insulin over time. And at some point, your body's like, I can't do it anymore. I literally cannot keep the balance. So you have cells that are full of glucose, and they have a couple of choices that are they're full up with glucose all the time. This is when insulin resistance starts to occur, because now what your body is doing, the cells are thinking to themselves, okay, I have two choices. I can just explode. I can commit suicide, apoptosis, or I can take this blood glucose and I can just start shoving it into the closest cells and the easiest route. And that is to shove it into adipose tissue, which is why most people with type 2 diabetes are overweight, very overweight, or extremely overweight. But you can interfere with this full-blown metabolic dysfunction once you develop type 2 diabetes early on. And certainly we can try to bring ourselves out of type 2 diabetes and, back into some semblance of, metabolic homeostasis. So primary dysfunction in a type 2 patient is insulin resistance and hyperinsulinemia. So insulin is too high rather in the bloodstream pretty much constantly, and yet the body still doesn't know what to do with it. So it just keeps popping out more insulin. So what you see with our medications are insulin and insulin secreting meds. And we need meds to reteach the body. Just telling the body to keep releasing more insulin from the pancreas and, dysfunctional beta cells isn't fixing the problem. So our old mechanisms of action, including sulfonylureas and insulin injections, they aren't enough. They were never enough, but they were the only thing we had for people with diabetes. Thank goodness we, had the. Hi, everyone. I'm sorry. I don't quite know what the problem is, but let me get the slides back up here and we will start where I left off. I'm not sure exactly where I was, but we'll go from here. All right, Dr. Stewart, can you see it? Everything?
I can, you're all set.
Okay. All right. Sorry about that, everyone. So biguanides, metformin, I was just saying that, certainly this was kind of the hope we needed for a new drug class when it came out several decades ago. And it sort of gave us a little taste of what would come eventually in the form of these peptides that really have revolutionized the treatment of so many diseases and conditions. And certainly here tonight, we're talking about type 2 diabetes and obesity medications. So you probably are not very familiar with the incretin system. I mean, we didn't talk about it much in, any medical curriculums, for good reason, because we didn't really have any drugs that would work on the system itself. But I want to just show you, kind of orient you to the system. We're not going to spend much time on this, but it does really help build the case for why naturally occurring peptides and peptides in drug form, why they are so key to treatment protocols for our patients, and not just in the form of type 2 diabetes and obesity, but in many, many different diseases and conditions. So I just want you to read the title. This says Pathogenesis of Hyperglycemia and Type 2 Diabetes. So pathogenesis of hyperglycemia and then ultimately type 2 diabetes. So sort of that pre-diabetes, that pre-metabolic syndrome, and then of course full metabolic dysfunction with type 2 diabetes. Now, so this slide is just very simple in the sense that it's showing you different levels in our body that would contribute to hyperglycemia and then ultimately type 2 diabetes. I want you to see something. First, over here, you can see that, oops, I got ahead of myself. You can see the red arrow is pointing to the incretin system. So in hyperglycemia and type 2 diabetes, the incretin system is decreased. We are going to want to increase that with our drugs. So this decrease in incretin effect, is contributing to much dysfunction, beta cell dysfunction, decreased insulin secretion. Initially, we got lipolysis, and then ultimately full beta cell dysfunction, hepatic issues, and glucose uptake is diminished in places like skeletal muscle. So it's a step-by-step approach. But first, I want you to see that the incretin system is decreased. We want to increase it. Over here, then to the right, I just want you to see two more things. In hyperglycemia and type 2 diabetes, our glucose reabsorption in the kidney is increased. So glucose reabsorption via the kidneys is increased, meaning more is hanging around. That's not good. And we have drugs that augment that now too. And then look at this last step. It's terrifying. Neurotransmitter dysfunction. So it's showing you sort of that connection between chronic slow burn inflammation and the fact that it doesn't just impact our waistline and a few silly little components. It can cause full dysfunction in our bodies over time, including dementia. And if you've heard me say this, I can't remember where I've said it before, but type 3 diabetes is Alzheimer's disease, and that is pretty well accepted in medicine. So our incretin mimetics, remember, we're trying to increase incretin. Incretin is glucagon in our bodies. So we have incretin mimetics, which means that we have drugs that are mimicking incretin. That is important. Drugs that mimic an endogenous substance or drugs that are mimicking an endogenous system are much more effective and well liked by the human body, more so than an enzymatic inhibitor. Keep that in the back of your brain. You're going to see that in a few minutes. So these are incretin mimetics, otherwise known as glucagon-like peptide 1 receptor agonists. So we've had some of these for years. Exenatide injection, it was Byetta, which was once per day, and then we got Bydureon, which was once per week. We still have liraglutide injection, Victoza. As a matter of fact, we had an original weight loss peptide, GLP-1 with exenatide, or with liraglutide rather. It was called Saxenda. Never really caught on. Then we've got a couple of others here. We've got dulaglutide, Trulicity, and then of course semaglutide, the drug that sort of changed everything. A couple of brand names, right? Ozempic is the one for diabetes. Wegovy is the brand name for weight loss, both sub-Q injections. And then there is also a tablet of semaglutide, an oral tablet called Rybelsus. It's only actually a labeled indication for type 2 diabetes, but we do see some patients use it for weight loss as well. The 30 tablets of semaglutide Rybelsus is the exact same price of the injectable semaglutide. I don't understand that, but here we are. And then there's just another incretin mimetic here that's not too popular, lixisenatide adalimumab. These are biologics, which means they're big structures, which means they're much more difficult to make than a small molecule chemical like, glyburide or glimepiride, or even metformin, right? The glyburide, glimepiride are sulfonylureas. Metformin is, of course, the biguanide. Big money, not only to manufacture them, but there's big money in manufacturing them and then selling them, certainly as drug therapy, right? So that's good and that's bad. We've had biologics for many, many years, but our newer biologics have really revolutionized the treatment of so many different diseases and conditions for sure. These are just some of the fancy pen devices that are available now for our injectable agents, specifically our glucagon-like peptide 1 agonist that we're talking about. So you've got semaglutide, Ozempic. This is what it looks like. You take the cap off of the pen. You put a tiny little needle that you screw on. It's called a pen cap needle, and you inject it. The dulaglutide, Trulicity, this particular type of device, same manufacturer that makes Mounjaro and Zepbound. So this one, you take the little cap off, kind of this foot here at the bottom, you place it on the skin, and then you press this green button. In Trulicity, it's green. You press it, and the needle fires itself into the subcutaneous fat. So, lots of different clever devices. Wegovy and Ozempic are semaglutide, same manufacturer. So those are the biologics. They're the only ones available right now, Wegovy and Ozempic. Eventually, there will be a biosimilar of semaglutide down the line, but that's going to be several years. So it's the same manufacturer, you can tell. The pens are a different color, but the dosing is tiny bit different between Ozempic and Wegovy because that's the only way that the company could get the FDA to also approve Wegovy. Like, I'm just going to change the dose a little bit. Maybe they won't notice it's the exact same drug. That's how you get another brand name and more money. How do these work? And then we'll get to tirzepatide, Mounjaro, Zepbound. These agents stimulate that glucagon-like peptide 1 receptor. This receptor is enhancing glucose-dependent insulin secretion by the pancreatic beta cells in response to high blood sugar. Now, let's say this again, because this is everything from a mechanism perspective. These agents, the glucagon-like peptide 1 receptor agonists, our liraglutide, Victoza, our semaglutide, Ozempic, Wegovy, and our tirzepatide, Mounjaro, Zepbound. That's a GLP-1 receptor agonist, but it also has a secondary mechanism as well. These agents are doing something exogenously via a drug that a body with type 2 diabetes and even a body that has been overweight, very overweight, or extremely overweight for a long period of time isn't able to do well at all anymore if it's type 2 diabetes, or not very well very often if it's someone who's overweight. And that is, you eat and now the pancreas is going to release insulin in response to food. These drugs fix that. So usually when somebody eats something with type 2 diabetes, or certainly type 1 diabetes, the pancreas doesn't really secrete enough insulin, or any insulin for that matter, depending upon the situation, in response to a meal. This drug actually mimics the ability to do that. So it's mimicking incretin and making it such that the pancreas is going to release some insulin in response to food. Already, the drug is changing the metabolic profile in these patients back to baseline, back or close to our normal homeostasis before the metabolic dysfunction existed. They suppress secretion of glucagon after meals. They slow gastric emptying, and they do have some appetite suppression and weight loss for sure. So notice that kind of the essence of that last little bit. It says slows gastric emptying, which we knew, and then some appetite suppression and weight loss. That was kind of the discussion with the liraglutide, Victoza, and the original drugs in this GLP-1 receptor agonist class, and that was Victoza, Byetta, Bydureon, etc. Patients with type 2 diabetes lost a little bit of weight, but not a heck of a lot. So then fast forward to kind of where we are now. We have newer chemicals in that group, the semaglutide, Ozempic, Wegovy, and now we have tirzepatide, which has brand name Mounjaro and brand name Zepbound. You'll see that in a second. So tirzepatide, as you probably know, was approved, within the last couple of years, at least the Mounjaro, and then the Zepbound, the weight loss version of tirzepatide, was approved this past summer. Tirzepatide is a twin creatine. So it's the first one in the class with many more to follow in the FDA waiting room, so to speak. But right now it's the only one that has the dual glucagon-like peptide 1 receptor agonists, like semaglutide, Ozempic, Wegovy, and a glucose insulinotropic peptide agonist activity. We call it the GLP and the GIP. It has both. This is the closest to an endogenous incretin system that's working well that is available. So if you've heard any, rumors out there or murmurings on the street saying that Mounjaro Zepbound seems to work better, it probably does. It really does in many patients. And I think that the GLP-GIP combo, like tirzepatide type drugs, are really going to sort of take the lead if they haven't already. These can significantly reduce glycemic levels and improve insulin sensitivity, as well as reduce body weight by more than 20% and improve lipid metabolism. So again, doesn't sound too impressive, but this is sort of the verbiage that was included with tirzepatide Mounjaro for type 2 diabetes. We sort of saw that just a slide ago here, some appetite suppression and weight loss. And that was essentially how the drugs were advertised for type 2 diabetes, because we'd already seen it with Victoza and Byetta, Bydureon, et cetera. We knew that patients with type 2 diabetes did lose a little bit of weight, but sometimes they gained the weight back, and it wasn't an extreme amount of weight. And then studies started looking at the semaglutide as a newer chemical, and then the tirzepatide. And we noticed that if somebody didn't have type 2 diabetes and they used the drug, or their type 2 diabetes was not too bad, or they had like metabolic syndrome, pre-diabetes, but not full-blown diabetes, that when they used these drugs, they lost a lot more weight than patients with type 2 diabetes. And they started to be evaluated for obesity, weight loss. Here's Zepbound. Zepbound is the brand name of the tirzepatide, the twin creatine for weight loss. So people, if you have identical twins, one has type 2 diabetes, and maybe they have like 120 kilogram weight, and then the other identical twin is 120 kilograms of body weight but doesn't have type 2 diabetes yet. They're right in the waiting room with metabolic syndrome, pre-diabetes. So if you give the one with type 2 diabetes semaglutide, Ozempic, Wegovy, whatever, and then you give the other identical twin that doesn't quite have type 2 diabetes yet but is almost there, the same drug, same dose, the identical twin that doesn't have type 2 diabetes yet is going to lose a lot more weight. In general, that's what we're seeing as a trend. And it's because they have not entered the area of kind of, I don't know if I want to say it this way, but I'm going to, because it's the word that pops into my brain, but almost like kind of a quote unquote irreversible metabolic stage, which is the type 2 diabetes. Now, some of you are thinking, wait, you can control type 2 diabetes with diet and exercise, right? So once you have type 2 diabetes, you can control it without drugs. You can control it with diet and exercise. Absolutely agree with that. But what we understand, and this is again, kind of just describing the metabolic dysfunction. Once you've crossed the line into, full-blown diabetes, you're never exactly the same as you were before. And what I mean by that is your body can be controlled with diet and exercise. The type 2 diabetes can be controlled, but your body is still never quite the same from a whole metabolic picture. You can be very healthy, et cetera, but you cross the line into that, metabolic dysfunction. Your body is never going to be quite the same as a result of that. And I don't mean that doom and gloom. I just mean that that's what we're seeing in patients. So adverse reactions, let's run through some of these. Both the twin creatine with tirzepatide and, of course, the glucagon-like peptide 1 receptor agonist, semaglutide, is really our prototype here. We know that gallbladder issues can be problematic. There are, a handful of cases that we've seen from the FDA over, 15 years when the first ones came out. Risk seems to be higher over time, which, kind of makes sense. The longer you use it, the higher the dose, the more likely it is to occur. There's a description of how it can present. Even if somebody's had their gallbladder removed, you can get gallbladder problems, or the colicky type pain. Additional issues, we know that these agents are contraindicated in people with a personal or family history of medullary thyroid cancer. So if you have a family history of it or a personal history of medullary thyroid cancer, it's an absolute no. Because it's the least likely type of thyroid cancer to have, but it's also the most aggressive. These agents can also cause loss of muscle. A lot of the, it's rapid weight loss with these medications, and part of that weight loss is skeletal muscle. So I was going to put actually in here, and I forgot, supplementing with making sure you get enough protein during the day, making sure that, maybe creatine as a supplement, I think is important for many, if not most patients using these medications. And then even like bioactive collagen peptides, that type of thing. That's the trio that I usually recommend for my patients on these meds. And then certainly Ozempic face. I don't know, this guy's got a pretty skinny face. I don't know if it's Ozempic face, but that's the picture that I found. But also monitoring for depression and suicidal ideation. These are pretty big hormonal fluctuations in patients using these medications. So we're watching that, watching it very carefully. And here, of course, are the two that are gonna make you think, oh gosh, I didn't know that, or maybe you did. So this isn't surprising. So maybe it's surprising. I tell you, it's surprising. It's been in the press quite a bit, in the past 6, 8, 10, 12 months that semaglutide and tirzepatide can cause worsening of diabetic retinopathy. We first saw this with semaglutide in 2018. It's a completely reasonable explanation, and it's something that we have seen with other anti-diabetes agents for decades. Semaglutide causes a relatively quick hemoglobin A1C reduction. I mean, not, it doesn't lower blood glucose rapidly like insulin or like our sulfonylureas, glimepiride, glyburide, glipizide. It doesn't work as quickly as that. But the metabolic transformation is so profound from the first dose that we do end up, seeing a drop in hemoglobin A1C, pretty quickly. I'm just going to check the question and answer real quick. So again, it's not surprising that we've seen this. The best way it's described as a transient worsening of diabetic retinopathy over the first 16 weeks of use of these agents. So what do we do about that? Well, we have to continue to monitor patients. Ideally, we would have interaction between the endocrinologist or the primary care or the weight loss practitioner and the optometrist, right? That would be ideal. But when you think about the logistics of that, usually a patient's coming in saying, hey, look, I lost 20 kilos of weight since I saw you last. And you're like, that's great, and patient says, my hemoglobin A1C is better, it's improving, I feel better, my blood glucose is heading in the right direction, I'm off all of my other diabetes medications, and I'm just using this. And then now you look in their eye and you're like, oh, you've got, a bleeder in the eye from the diabetic retinopathy. We know that this occurs with the agents that lower blood glucose. And, it's something that we're watching over time. I think a question popped up. Then we also have here something that popped up just this past July. Let me see if I can get this question to pop up. Something that popped up over in July from JAMA Ophthalmology, and that is non-arteritic ischemic optic neuropathy. And that's something that is popping up as well. Oh, here we go. Now I can see it. So what do we do about this? We monitor. It says, what about effects on peripheral neuropathy, i.e. numbness in feet, et cetera? So if I'm misinterpreting the question, let me know. But I guess the question would be, is it worsening peripheral neuropathy, or are you asking if it could improve peripheral neuropathy? I have not really heard of anybody saying that the peripheral neuropathy has been worse. because of this, but again, big fluctuations and changes in blood glucose. But I have heard patients saying that they've had some improvement in their peripheral neuropathy. But again, qualify the question if you need more information on that. But even the NAION, this is something we have to watch. I mean, the data that came from JAMA 2024, July 2024, in the JAMA ophthalmology article manuscript basically said that there was a fourfold increase in people using these medications. It was specifically semaglutide and non-arteritic ischemic optic neuropathy. So I actually had a very lengthy conversation with a neuro-ophthalmologist here that I lectured with a number of months ago. Anyhow, he's, very, very, very smart guy, good friend. Anyhow, I said, what do you think about this new NAION as a problem? And he's like, I don't know. I think we just need more information. We just have to watch. So the recommendations right now are, to watch patients that have history of NAION, low vision already, or vision impairment, or monocular vision. So time's going to tell. Time is going to tell. And maybe you were asking that question because it's neuropathy in the eye. We'll see. I don't know what to say about that. We need more information, to give a good evidence-based recommendation on this. So anyhow, I just wanted to throw this in here. The original DCC trial, diabetes control and complication trial, was from the 90s. And we knew then that there could be a worsening of diabetic retinopathy. So this is not a new thing. I think it's just been in the press so much that people are surprised. So these are a couple of trials that are ongoing with both semaglutide as well as tirzepatide. We expect more answers on the diabetic retinopathy discussion this year in 2025 for semaglutide, and it'll probably be 2027 for the tirzepatide. I was just making sure I didn't get kicked off again. So we'll see. We have some good direction, interfacing between practitioners, monitoring the patient, but I don't think it makes sense to really say we're not going to put you on this drug because of, we're worried about worsening of your diabetic retinopathy, because long game is that the diabetic retinopathy will improve because of better blood glucose control. So we're going to play it by ear, maybe increasing the dose more slowly, because we definitely start low and, fairly rapidly increase the dose of semaglutide and tirzepatide based upon how patients tolerate it. So we'll see. Don't forget the DPP-4 inhibitors. So remember I said there's an enzymatic reaction that can occur. And I said, if you have an incretin mimetic, that's a much more powerful, well integrated mechanism that the body will use compared to something that's an enzymatic inhibitor. So the DPP-4 inhibitors, DPP-4 is dipeptidyl peptidase 4. This is the enzyme responsible for cleaving, for breaking down incretin. So these agents inhibit the breakdown of endogenous incretin. Still impressive, but not as good in terms of weight loss as our incretin mimetics, the glucagon-like peptide-1 receptor agonists and the glucose insulinotropic peptide agonists. So you probably have heard of sitagliptin, Januvia. I mean, we're seeing just remarkable results for heart failure from this agent, et cetera. So we're seeing some really positives from this incretin group of drugs. And most specifically, these are oral, by the way. The DPP-4 inhibitors are oral agents. But our GLP-1 receptor agonists, our semaglutide or tirzepatide, we are seeing not only a better an improvement in somebody's BMI and how they feel and their autoimmune disease, but we're seeing, decreased cancer risk. That's being evaluated now with good results. We're seeing longevity results. I mean, these agents are drugs that are going to be considered anti-aging longevity medications because they're fixing the problem of that chronic inflammation. And certainly we are already seeing heart failure benefits, profound ASCVD benefits as well, atherosclerotic cardiovascular disease. So it's just going to get better. We don't really use the sulfonylurea as much anymore as new agents. Patients are on them, we keep them on them. But, our favorites are like glimepiride and glipizide. But the sulfonylureas are asking a sick pancreas to release more insulin. That's all they're doing. So in terms of evidence-based medicine, we don't have the decrease, morbidity and mortality data like we do with metformin and the new agents, semaglutide and tirzepatide. Insulin preps, those are never going to go away. Exogenous insulin injections work better when they are paired with some of these incretin drugs and or metformin, for sure. Our body, is looking the closest it can ever get to what it had before metabolic dysfunction. And then we have our SGLT2 inhibitors, our sodium glucose cotransport 2 receptor inhibitors. So these agents, the flozins as we call them, canagliflozin Invokana, dapagliflozin Farxiga, and empagliflozin Jardiance, great stuff coming out with these agents as well. These are making the body pee out more sugar. That's a good thing, but we're also seeing cardiovascular benefits from them, and heart failure, which of course is cardiovascular. So lots of good stuff. Don't forget that, hypertension is part of that metabolic syndrome, metabolic disease issue. Hyperlipidemia is an issue as well. You see a lot of people getting put on rosuvastatin, Crestor nowadays because we can treat really bad lipid problems with rosuvastatin. It's the most potent agent. And actually, rosuvastatin, of all of the statins, is probably the best tolerated. And rosuvastatin is, showing some anti-inflammatory and maybe even some decrease in cancer or cancer recurrence benefits. So use that along with our semaglutide, tirzepatide. Just, hang on for the ride. We're going to see some pretty decent outcomes. And then we have some of our older agents. I just want to pop through these real quick. Niacin and our fish oils as well, certainly important. But, as we kind of get towards, get a little bit more towards the end and time for questions, you need to keep in mind that what these prescription peptides can do is be the great equalizer, along with, of course, our fruits and vegetables, our rainbow of fruits and vegetables each day, and that come from our foods, but also supplementation. Almost everybody needs some supplementation to their diet. But this is what we're fixing. All the stuff that we've been exposed to, from the time we were conceived, from the time we went from 1 cell to 2 cell to 4 cells to 8 cells to 16 to 32 to 64, 128. We are constantly bombarded with oxidative stress and toxins and, things that our bodies are exposed to before, we were even considered like, hey, our parent knows that we're actually pregnant. We can actually change how genes are responding. We might not be able to actually change our genetics, but at least the gene expression we can change with some of these meds and dietary changes and supplementation. So, I already kind of gave my spiel on antioxidants. You guys are already the experts. My one plea to you as optometric physicians would be just a simple question. And, why is it that we want to just, kind of hit the inner retina with our lutein, zeaxanthin, et cetera? We maybe really should be approaching this from a more comprehensive perspective, because the eye is end organ disease, right? Same with the heart, same with, cancers, et cetera. And I just, asked the question, why is it that we want to just target the inner retina? What if we could hit the entire systemic system? It's redundant, but our entire body, including lutein, zeaxanthin, and be able to support everything from an oxidative stress perspective. That is key. Here's, kind of the cell membrane, looking at all of these vitamins and minerals and, some of the stuff that you guys certainly use as optometric physicians. But every nutrient, every mineral, every polyphenol, every carotenoid, all of these things work in our body as cofactors. So we can't just recommend and prescribe in a vacuum, such that we're just saying, I just want to, support your retina and your macular, potential for macular inflammation and disease. While that is beneficial for sure, and it certainly is better than nothing, we have to remember that our body is working together with all these vitamin minerals outside of diseases, all these nutrients, antioxidants. They need each other to work well, including omega-3s and fish oil. We already mentioned the significance of the gut microbiome. This is just a real quick clipping of things that I saw, but everybody knows about probiotics, right? These are the good bacteria, the beneficial bacteria. Not all probiotics are created equal. I have two that I like, and sort of for different reasons. But recolonizing our gut shouldn't be an everyday occurrence. We shouldn't need a probiotic every single day for the rest of our life. We should recolonize our gut with beneficial bacteria and then feed the garden that we've just laid down. And we feed it with prebiotics. Prebiotics are, our soluble and insoluble fibers, all our good foods, et cetera. That's what we need in order to produce the whole point of all of this, which will be the postbiotics. And these are going to be the endpoints of what happens when you have beneficial bacteria plus the prebiotics. You end up with butyrate and propionate and all these wonderful chemicals that are working to create a wonderful gut microbiome, to keep it in check and really to contribute to decreasing this chronic inflammation. And then I also wanted to mention, there are some, if you've ever heard of peptide therapy, lots of med spas and, different practitioners have used IV peptides for a long time. Individual states are really cracking down. The Food and Drug Administration is really cracking down on IV peptide therapy. I don't understand it. I think it's because it's competing with prescription medications. That's my tinfoil hat perspective on it. But there is room for supplementation and prescription drugs for sure. So anyhow, there are a couple of companies that are now working on oral bioactive precision peptides. And think about it, bioactive precision peptides. It's kind of like the same thing you can do with some antioxidants. You can make them individualized biotherapy. That is, that's what we should be doing with our patients, not just a blanket recommendation statement for everybody. We need to tailor it a little bit. And we can do that with our supplements and our food and, the way that we measure it. But now we have these oral peptides, and I'm about it. I think it's going to be a game changer. So think of them as some of them as like little mini versions of Ozempic, Wegovy. They're not drugs. They come from nature because, Mother Nature is the ultimate biochemist for sure, right? We've got this beautiful laboratory in nature where we have plants, animals, and microbes that contribute to this beautiful, intricate web of life, that we've relied on for, millions of years or however long you think we've been around as organisms. So these bioactive precision peptides, they're coming down the pike. If you want any more information, let me know. You have my email embedded in here and certainly my cell number if you want to text me. But think of them as like supplements, but much more individualized. So it's not like just everybody Centrum Silver for everybody, or, Kirkland brand multivitamin for everybody, or AREDS 2 for everybody, or whatever, just some that I thought of off the top of my head. This is precision supplementation and individualized. Obviously, that's the precision part for greater targeted efficacy. They're over the counter, they're natural ingredients with no junk. Sugar, alcohols, and all that, none of that. And these are some of the categories: focus, energy, visceral fat loss, skeletal muscle growth and maintenance, and even hydration. So I'm really excited about this kind of new category of supplementation that will be coming out.